Leave now, otherwise you're remaining as you're implied to consent to be in the program with us. The program this evening is two lectures, which will provide 1.5 hours of Category 1 AMA Physician CME credit and 1.5 hours of nursing, Virginia Nursing Association CE credit. Sovah Health is accredited by the Southern State CME Collaborative, an ACCME recognized physician CME accreditor. And similarly, we're accredited by the Virginia Nurses Association to provide nursing CEs. The program this evening was developed in order to promote three desirable physician attributes, including our providing patient-centered care utilizing evidence-based medicine information and practice, and uniquely the use of informatics tonight, which Dr. Fadim will be talking about in the second talk. Both of our speakers are well-respected national experts and international experts in their areas, and both have reported a number of relationships with commercial entities that are summarized for you here. Both speakers tonight, and I'll show you Dr. Fadim's list in just a moment, have agreed to a mitigation plan for these relationships that include providing their slides for CME review prior to the program, which I did, and there's no evidence of commercial bias in those slides. And then they're testing and agreeing to whatever they present will be clinical recommendations that are based on evidence-based medicine, free of any commercial bias, coming from peer-reviewed literature and/or evidence-based medicine consensus guidelines. These are the relationships for Dr. Fadim, and he likewise has provided his slides, and they're fine. And he also has attested that he will do his presentation free of any commercial bias. His recommendations will be from evidence-based medicine, peer-reviewed materials, and/or evidence-based consensus guidelines. Myself and members of the Sovah Health CME committee who developed this program have nothing to disclose as far as commercial relationships. The program this evening does not have any commercial support. It, like all of our CME programs that we provide, is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, the founder of the Southside Urology Nephrology Clinic, previously known as the Danville Urologic Clinic, established this fund, this endowment for medical education upon his retirement a number of years ago, with the purpose that it would be used for healthcare professional education, continuing education throughout our area here in Southside Virginia. We're very grateful for that support. This evening, after the program, you will receive an email and evaluation form. Mary Ken is also embedded in a slide I'll show you in just a moment. A code you can take a picture of with your camera if you want to access the eval form that way. Once you get the eval form on your device or computer, you will be asked to re-enter your name and your email address. Please give us your full name, since the name you entered there will be what will be on your CME certificate of your attendance that will be emailed to you once we get the eval form back. For the physicians on the call, eval forms are not required for you to receive a certificate. However, for the nurses and nurse practitioners, you must submit an eval form in order to get the CME certificate of your participation. If you're sharing a log on this evening, which is perfectly fine with someone else, so please let myself, Mary, or Van Holt know, so we can be sure that everyone at your site gets credit for their attendance. This is the QR code that Mary will put into the Teams chat box towards the end of the program, which you can click on to get to the eval form if you prefer to do that. For the medical residents, the Sovah residents on the call, please know that your program coordinators, Dara Johnson, Laura Galvez, will basically track your participation. You do not have to collect CME certificates, so you'll be sent those electronically. And then finally, I want to just thank, as I do each time we do a program, Mary, Ken, and Vandora Holt for helping us organize the program this evening. Van is responsible for the nurses CE credit that we're able to provide, and Mary Kent does the bulk of the work that allows us to organize and present the programs to you. So many thanks to them. I know both speakers encourage questions, and I hope you will come forth with questions. They're happy to be interrupted, and or if you'll put it in the chat, Mary will monitor the chat and forward it to them as soon as possible. If you ask a question or have a comment, both of which are welcome, we ask you to, once you've asked your question or made your comment, please mute your phone so we don't get feedback. You're encouraged and welcome to make as many comments, questions as you would like to make and which time allows, but just mute your phone once the speaker starts responding to what you've asked. Let me highlight for you briefly what's coming up next. On March 13th, we're delighted to have Dr. Tobe from the Cone Health Center for Health Equity in Greensboro speak to us on using health equity in maternal health. Dr. Tobe is the director of the Women's Heart Health and Cardio Obstetrics Clinic at Cone and is really a very unique educator. The other program that will occur at the end of March is an OBGYN program about gestational hypertension, preeclampsia, and eclampsia. Preeclampsia, as many of you may know, has been increasing throughout our country for the past several years. It ended up with a huge article in the Wall Street Journal focusing on the importance of early recognition of elevated blood pressures in pregnancy and or albuminuria in pregnancy. So we're delighted to have Dr. Obianzi, one of our residents, work with Dr. Phil Honea, one of our local OBGYN physicians, to review this for us, tell us how this can be recognized in the prenatal period, and just as important, how it should be managed and treated. So I hope you'll join us for one or both of those programs. The program this evening is the third in a series of cardiology programs that we usually do every February, a heart month as it were, typically. And because we had so many things to try to cover in February and March, we ended up having our third program here at the beginning of March. We covered so many in February, we had to spill over into March. Both of our speakers tonight are from Duke. Both are advanced heart failure specialists. Dr. Green's going to begin by talking about the medical management of patients hospitalized for heart failure along the American Heart Association and American College of Cardiology guidelines. He began his educational journey in Connecticut, his home, where he went to initially Brown University, receiving a Bachelor of Arts degree in biology and economics, graduating magna cum laude, and being selected for Phi Beta Kappa as an undergraduate. He went on to Northwestern in Chicago for medical school, where he was selected for Alpha Omega Alpha, the Academic Honor Society for medical students in medical school. He then did his internal medicine residencies at McCall Medical Center and came to Duke for fellowships, which he completed in clinical cardiology, clinical research, and advanced heart failure. Dr. Green remained at Duke once he finished his fellowship sequence and has been a faculty member there as an advanced heart specialist since that time. He is a well-respected international expert on heart failure, serves as a reviewer for almost a dozen major cardiology high-impact journals. To my understanding, he is basically a reviewer for every cardiology journal that currently exists. He's had over 180 publications, and he has an extensive teaching and mentoring of current fellows experience at Duke. We're delighted to have Dr. Green back. He actually was invited back to our heart failure care teams on both campuses, wanted him to come back. He was with us a year ago, and he's going to update that talk with anything that's new and helpful. So Dr. Green, if you'll bring your slides up, mine, I think, will fall off. Thank you so much.
Perfect. Well, thank you so much for that introduction, and I'm going to try to share my screen here.
Yeah, that's good. Looks good.
All right. Okay, so everyone can see my screen now, it looks like. So again, thank you very much for the introduction, and really a pleasure to be back with everyone this evening. So we're going to be talking about a very important topic that we all are seeing in every hospital across this country, and that's how do we medically manage patients hospitalized for heart failure? So to set the stage for the condition that we're talking about today, it's really important to put heart failure risk in its true context. We all know heart failure. We hear the phrase like high risk, and we think we know what that means, but the reality is the phrase high risk gets thrown around all the time with all these different medical conditions under the sun. Every subspecialty has their own version of high risk patients, they would say. But the reality is not all high risk patients are created equal. It's important to anchor that relative, that subjective terminology, high risk, to the actual absolute risks of bad things happening to patients. And when you do that, you realize again that they're not all created equal. And conveniently, within cardiology, we have the cholesterol guidelines, which for some time now have been using terminology we've all heard about, like borderline risk, intermediate risk, high risk, very high risk. And when you look at those criteria, you would say that someone who meets the criteria for high risk in the cholesterol guidelines would have about a 2 to 5% per year risk of heart attack or stroke. And they even have this phrasing of very high risk. And the people who meet that criteria for very high risk have about a 5 to 8% per year risk of heart attack or stroke. Now, I certainly would agree 5 to 8% per year risk of heart attack or stroke seems like very high risk to me. I wouldn't want that to be my own risk of heart attack or stroke. But the truth is, if we're going to call 5 to 8% per year very high risk, what on earth are we going to call our patients with heart failure? Even our quote unquote stable heart failure patient. The patient has never been hospitalized, NYHA class 2, comes to your clinic in the outpatient setting with no complaints. We're talking about a 1 year risk of cardiovascular death or heart failure hospitalization of 10% per year. We can't get risk in heart failure lower than that. And then we have our patients that are hospitalized for heart failure, really the topic of this evening's conversation. Here, we're talking about a 1 year risk of CV death or heart failure hospitalization of 40% per year. So again, if we're going to use these terms like high risk and very high risk to describe all these other medical conditions, heart failure by comparison is truly an extreme high risk or even very extreme high risk condition. So I want us to remember that risk profile when we're talking about the rest of our conversation tonight. And with that background, we're going to be having a kind of generic outline here. Medical management of heart failure. Two key things we need to discuss tonight: diuretics and guideline-directed medical therapy. And we're going to start the conversation with just taking a step back and asking ourselves, well, what is the status quo that's going on every day in this country across hospitals? And let's first think about diuretic therapy. How are diuretics actually used for our patients hospitalized for heart failure? Well, this is an analysis from a nationwide study that was published a few years ago now, looking at patients hospitalized for HFrEF and what was their pattern of in-hospital diuretic use. I'll direct your attention to the top panel, the green color. These are patients that I would call had an uncomplicated diuretic management strategy. That is, they presented to the hospital. We picked an initial dose of IV diuretic, however arbitrary that initial dose might have been, but we don't have to escalate it at all. They seemingly respond to this initial dose that we arbitrarily pick, and then we either gradually decrease the dose or we discontinue it and the patient goes home. About 2 out of every 3 patients hospitalized for heart failure have that very crude and simplistic, easy diuretic management plan. The other third of patients, this is where it gets a little, you see some creativity. You have about 10% of patients where you're having IV diuretics stopped and then restarted after they've been paused for at least a day. So there's kind of the start and stop phenomenon. You have another almost 10% of patients where you're having add second adjunctive diuretics. And then you have about another 10 to 15% of patients in that red color. There's the people that are, you give them initial dose diuretics, but things are really going off the rails and you have to escalate to mechanical support, IV inotropes or IV vasodilators. Point here is, though, that yes, We all have those challenging patients that are, again, we're doing all sorts of creative things with our diuretics. Not a lot of good guidelines to guide us. But again, 2 out of every 3 patients have a very crude and simplistic, easy diuretic management strategy in the United States. Well, that's the status quo with diuretic management. What's the status quo with in-hospital management of GDMT? And here we have what I call an overwhelming culture of clinical inertia. These are data from the Victoria Registry, published a few years ago, looking at North America clinical practice, United States and Canada. And the big take-home point here is that among patients hospitalized for worsening heart failure, patients generally presented to the hospital on stable sub-target doses or no dose of GDMT at all, and they left on stable sub-target doses or no dose at all. There was very minimal initiation or escalation of GDMT during the in-hospital encounter. And it's really all culminated at time of discharge, where you have vital signs looking like median systolic blood pressure 110 to 120, median eGFRs 50 to 60. Both of these parameters would strongly suggest that if we weren't falling asleep at the wheel, we had room to escalate or initiate GDMT. Well, despite those parameters, among eligible patients, we had more than about 1 in 3 not going home on any dose of ACE/ARB ARNI, 1 in 4 going home on no dose of a beta blocker, and more than half going home on no dose of MRA. So now that we understand what the status quo situation is like in the United States, let's talk about some of the data. And let's first start with diuretics and talk about some of the old school classic data that we have with diuretic management. So historically, there haven't been a lot of big blockbuster trials in the diuretic space, but this is one trial that was done more than a decade ago that still gets a lot of discussion. This is the DOSE AHF trial. This was actually led by Dr. Michael Felker, who's one of my colleagues here at Duke. This was a modestly sized trial of only 308 patients hospitalized for heart failure, both HFrEF and HFpEF. And it asked two very simple questions. Does giving diuretic as a bolus versus continuous infusion matter? And does giving high dose versus low dose matter? And the primary endpoints in this study were a global assessment of symptoms and change in kidney function. So to cut to the chase, for the continuous infusion of loop diuretic versus bolus of loop diuretic, absolutely no difference in any of the clinical endpoints. But there was a pattern that emerged when you did the comparison of the high dose versus low dose. Generally speaking, we saw that with the high dose compared to the low dose had improvement in symptoms and improvement in decongestion. Change in weight was statistically significant more volume loss, incremental lowering of NT-proBNP was borderline significant. Came at the price, though, of a higher chance of bumping your creatinine. So again, this is something that I think we see all the time in our clinical practice. If it kind of makes common sense, if you escalate diuretics, yeah, sure, you might improve congestion measures, but sometimes it comes at the price of increasing the creatinine. And it's this creatinine that I also want to have a little extra focus on too, because I feel like this comes up all the time in the hospital, and it's a big source of clinician anxiety and hesitation. What do you do when you're diuresing a heart failure patient and the kidney function worsens? Well, the first thing to realize is that not all quote unquote acute kidney injuries are created equal. The context matters. And I'll show you data on this slide that have been replicated in study after study. And the bottom line is, if you have a bump in your creatinine while you are successfully decongesting patients, that bump in your creatinine has no prognostic significance whatsoever. Usually we're thinking, oh my God, the creatinine is getting worse. That must mean the patient's at higher risk of kidney failure, death, all sorts of bad things. But if you're doing this, if your kidney function is worsening in the setting of decongestion, again, to a point, not to the point of dialysis, but again, modest decreases in kidney function, no adverse prognostic significance. In contrast, if your kidney function is worsening and you're not successfully decongesting the patient's not responding to your diuretic plan, or you're not diuresing at all and they're just having worsening kidney function, that of course is prognostic. But again, if your patient is still substantially volume overloaded and the kidneys are showing worsening, generally speaking, the best thing for that patient is to keep going and focus on making the patients feel better, and the kidneys are going to do what the kidneys are going to do. So now let's get to another angle of the conversation. So in a perfect world, when we're taking care of our heart failure patients, both inpatients and outpatients, we would achieve two central goals. We would have all our patients on maximally tolerated or target doses of GDMT, and they would all be completely euvolemic on appropriately dosed diuretic therapy. These are the two central goals that would be achieved in all heart failure patients if we were living in a perfect world. But the obvious truth is we do not live in a perfect world. And while we oftentimes chase appropriately these two central goals, oftentimes there is tension between decisions to increase diuretics and chase the euvolemia, or do we spend that borderline blood pressure and kidney function on escalating GDMT? And we have medical students and residents at our hospital at Duke, and they often get taught really these two dogmas. And certain people talk a lot more about one versus the other. But anyway, the two dogmas that you're going to hear as a trainee are: get the patient euvolemic. We need a diurese to euvolemia. If you leave them congested at discharge, associate with higher chance of readmission. And then dogma 2 is, well, we need to optimize GDMT prior to discharge. But again, if you can only pick one, and we acknowledge that both are important, when push comes to shove and you have a borderline blood pressure or borderline kidney function, which of these two dogmas do you prioritize? And it comes down to this central clinical situation right here. You look at these two patients on this slide and you ask yourself, which of these two patients, I guarantee are in hospitals across the country right now, representative patients, which of these two situations is the patient better off? Patient A, where the patient is completely euvolemic at time of discharge, no normal JVP, no edema. You see the blood pressure and creatinine are there, but they're only prescribed 3 out of the 4 pillars of GDMT at discharge. Versus patient B, patient's feeling okay, you've decongested them a bit, but they still have elevated JVP, still have mild edema. Congestion status is definitely not perfect. They have the same vital signs as patient A, but this patient is prescribed 4 out of 4 pillars of GDMT. So which of these patients is better off? The one who's prescribed 4 out of 4 pillars, but still somewhat congested, versus the person who's completely euvolemic, only prescribed 3 out of 4 pillars. And it comes down to, again, survival, readmission, quality of life. What are the data supporting which of these two patients are better off? So let's first talk about what is the randomized evidence for supporting intensification of diuresis. So again, yes, we need to use diuretics. We need to take the edge off. Loop diuretics are the mainstay. But again, really stepping on the gas pedal with intensification of diuresis. What are the data? So one clinical trial that came out recently, the last few years, was a TRANSFORM trial. And this was a trial that we led at Duke. And this took patients hospitalized for heart failure and randomized them to one of 2 loop diuretic strategies, either torsemide versus furosemide. And for those that might be aware, torsemide is a more potent, and we think generally stronger, quote unquote, diuretic than furosemide. But there had really been no head-to-head trials if a quote unquote more potent diuretic would improve clinical outcomes. And you see, we had primary endpoint of all-cause mortality, and we also looked at all-cause hospitalization and quality of life during post-discharge longitudinal follow-up. So these are the primary results for TRANSFORM, for the primary endpoint all-cause death. Absolutely no difference whatsoever with using furosemide versus torsemide for patients hospitalized for heart failure and continuing at post-discharge. And again, torsemide being a quote-unquote historically more potent, stronger diuretic did not improve mortality. Likewise, there was no significant benefit on all-cause hospitalization and no change in quality of life. So in this case, using the quote-unquote stronger diuretic did not improve clinical outcomes or quality of life. Well, let's talk about another clinical trial that came out a couple of years ago, and this is the ADVOR trial. Now, the ADVOR trial was a about 500 patient trial that occurred in Europe, and this took patients hospitalized for heart failure regardless of ejection fraction. All the patients were treated with a standard loop diuretic regimen, but half the patients were randomized to standard loop diuretic regimen alone versus standard loop diuretic plus addition of IV acetazolamide. Now, the primary endpoint here was successful decongestion at 3 days post-randomization. This really was an in-hospital decongestion trial. That was the primary endpoint. And successful decongestion was defined as absence of effusions and ascites and no more than trace bilateral edema. In any case, for this primary endpoint of successful decongestion at 3 days, adding acetazolamide to loop diuretic therapy was superior compared to loop diuretic therapy alone. It did have a higher chance of successfully decongesting the patient. But when you take a step back, this might not be that surprising. I mean, really, you could distill this down. Is this really just a trial of 2 diuretics versus 1 diuretic? And should we be that surprised that 2 diuretics leads to less edema and less ascites and less pleural effusions? But needless to say, there's really a dearth of positive clinical trials in the diuretic space, and this was published in the New England Journal of Medicine. So to me, while again, I'm happy it was a positive trial for that primary endpoint, not necessarily that surprising that you can have some more decongestion with 2 diuretics versus 1. So it really comes down to what else does addition of IV acetazolamide seem to offer? Well, it seemed to offer a modest reduction in hospital length of stay in about 1 day shorter with adding IV acetazolamide, which I take it as a victory there. Anytime we're shortening length of stay, that's great news. But the truth is, it didn't have anything else to offer. There was no change in patient-reported quality of life with adding acetazolamide to standard care. No benefit whatsoever on post-discharge hard clinical outcomes. In fact, the risk of mortality and hospitalization for heart failure was, if anything, going in the wrong direction towards higher risk with adding acetazolamide, although it was not statistically significant. But at least you could say that addition of IV acetazolamide seemed to be safe. There was no significant difference in hypotension and electrolyte abnormalities, kidney issues, SAEs. So at least it was safe. But again, talking about improving hard outcomes and making patients feel better, I would argue acetazolamide did not achieve that aim. And then shortly after the ADVOR trial with acetazolamide came out, there was another clinical trial that was very similarly designed called the Chlorotic trial. And this time, instead of testing in-hospital initiation of acetazolamide, here we were doing in-hospital initiation of a thiazide, hydrochlorothiazide. This was, again, another trial of 2 diuretics, thiazide plus standard loop versus loop alone. Now, there's a co-primary endpoint. One primary endpoint was change in weight over 96 hours, and 2 diuretics versus 1 diuretic. 2 diuretics did lead to modest improvements in weight loss. But the other co-primary endpoint was dyspnea relief. No significant difference with adding hydrochlorothiazide to loop diuretic. 2 versus 1, no improvement in patient-reported quality of life. Like ADVOR, there was no improvement whatsoever in post-discharge hard clinical outcomes, readmission risk, mortality risk. Getting the patient with that extra weight loss did not translate to hard clinical outcomes improvements. But there was the price to pay here with adverse kidney effects and hypokalemia. So again, Chlorotic now, a second trial where you have incremental decongestion with weight loss, no improvement in hard clinical outcomes, no improvement in patient-reported quality of life. Another trial that came out in 2023 called the PUSH-AHF trial. This was a strategy trial of patients hospitalized for heart failure. Half the patients were randomized to standard of care, loop diuretic management, do what you normally do. The other half of the patients were randomized to natriuresis-guided diuretic management. This was checking urine sodiums. And if the urine sodium was low, you would then be instructed to follow a protocol and escalate diuresis accordingly, kind of chasing a goal, urine sodium. So looking at the left-hand panel, the blue line is natriuresis-guided therapy, and this is total cumulative natriuresis, how much urinary sodium was excreted. Natriuresis-guided therapy led to more natriuresis. Perhaps not that surprising. For example, if you're randomizing people to measure their blood pressure versus not measure their blood pressure, we're guessing the people that you measure blood pressure in are going to have better chances of controlling their blood pressure. So anyway, but again, led to more natriuresis, led to more diuresis. Again, incremental decongestion when you do natriuresis-guided therapy. But the other side of the coin, no significant effect of this extra diuresis, extra natriuresis on death or heart failure hospitalization. No effect whatsoever on hard clinical outcomes. And then we even have mechanistic data going back to the TRANSFORM trial that I showed recently. Again, this was the torsemide versus furosemide comparison. We did a sub-study looking at natriuresis with the two loop diuretic agents. Guess what? The more potent diuretic, torsemide, as dosed in this clinical trial, led to more natriuresis and more diuresis than furosemide. That's what you'd expect with a stronger loop diuretic. But did this increase natriuresis by us anything else? Again, I remind you, in TRANSFORM, there was no difference in mortality, no difference in hospitalization, no difference in patient-reported quality of life. And in fact, in this sub-study, we measured renin, aldosterone, other neurohormones. There was more neurohormonal activation with torsemide. So yeah, we're making our patients urinate more natriuresis, but potentially at the price to pay of ramping up all those bad neurohormones that we're trying to block with our GDMTs. So to summarize it for diuretic management, of course, diuretics are the cornerstone of symptomatic management of heart failure. Of course, when a patient comes in fluidly volume overloaded, of course you need to diurese them. But the bottom line with diuretics is that we don't have data for really going for perfect and for going for that incremental diuresis above just a reasonable job. It does not, convincingly in the clinical trial data, show improved outcomes or patient-reported quality of life. So now let's transition to optimizing GDMT for patients hospitalized for heart failure. So when we're talking about our patients with HFrEF, we know now the 4 pillars of GDMT. There's ARNI therapies, cubitril/valsartan, beta blocker therapy, MRA, SGLT2 inhibitor for HFrEF. These are all class 1 level of evidence A recommended therapies. But the thing is, not only do these therapies work, and we need to understand that, but we need to understand that these therapies work very, very well. The magnitude of risk reduction is immense, such that you look at analyses like these, they estimate that the cumulative risk reduction for all-cause mortality, if you use all 4 pillars versus none, we're talking about a 73% relative risk reduction, an absolute risk reduction of 26%, a number needed to treat of less than 4 to save a life. But unfortunately, whether it's the inpatient setting or the outpatient setting, myself and colleagues have proposed we need to break this culture of clinical inertia, and that is to have simultaneous or rapid sequence initiation of these quad therapies for HFrEF. I talk here about starting all 4 mortality-reducing drugs on day 1 if you're in the outpatient setting or within 1 week, or if you're in the hospital by time of hospital discharge. And you need to prioritize initially at least low doses of these 4 medicines. There's only 1 dose of SGLT2 inhibitor. And after you achieve at least priority number 1 of at least a sprinkle of all 4 medicines, then we focus on up titration to target doses or maximally tolerated doses over the coming days to weeks. Well, sounds great, but what are the data supporting rapid sequence or simultaneous or in-hospital initiation of all 4 pillars for HFrEF? Well, it comes with realizing that for all 4 of these drugs, it doesn't take months or years for clinical benefits to show up, but just within days to weeks of starting these medicines, you see very early separation of event curves, substantial reduction in hard clinical events, such that you can easily understand that delayed initiation of any of these 4 drugs in an eligible patient equates to needless exposure to excess clinical risk. And then when you also recognize that all 4 of these medications are fully additive to each other. And then when you remember my very first slide showcasing how heart failure and patients hospitalized for heart failure are really at a very extreme high-risk patient population, we need to leverage the fully additive benefits of all 4 of these drugs and use every tool in our toolkit to lower our patient risk. But the truth is, when you have a patient hospitalized for heart failure and you don't discharge them on all of the pillars of medical therapy for which they are eligible, of course, that leads then to needless exposure to excess clinical risk for this extreme risk patient. But the truth is, when you defer initiation and hospital discharge, that's really the same as never initiating medication at all, or at best, substantial delay. And don't take my word for it. We just look at the real world evidence supporting this. These are data from the Get With the Guidelines Heart Failure Registry, which is a nationwide US heart failure registry. And we take people that are eligible at time of hospital discharge, but you defer. You say, you know what, I'm the diurese and discharge clinician. I don't want to step on the outpatient doctor's toes. It's up to the outpatient team to start that beta blocker or start that MRA. If you take that approach, looking here for ARNI and MRA in the orange color, you have more than a 75% chance if you discharge the patient without those medicines, that eligible patient is not going to fill a prescription over the entire 1 year after they leave the hospital, more than a 75% chance for both ARNI and MRA. You see in blue or teal, if you do prescribe the therapy, they certainly aren't guaranteed to fill it at the pharmacy, but they have a much higher chance of getting access to that life-saving medicine. So again, we need to not shirk our responsibility when we're taking care of patients in the hospital. We're not just the diurese and discharge clinicians. We need to focus on using the hospitalization as an opportunity to optimize GDMT and to make sure patients are prescribed at hospital discharge all of the GDMTs for which they are eligible. But, you know, when I talk about starting multiple medications in short order at all at once simultaneously, people often look at me like I have two heads and they say, gosh, Steve, how can you start so many medicines so quickly? Aren't you worried about intolerance or side effects and all this stuff? And I say, well, just take a step back and think, what do we do for our average patient hospitalized for acute MI or a STEMI that has new LV dysfunction? Patient might have been walking down the street on no medicines whatsoever, having no cardiac history. They have their acute MI. They're rushed by EMS to the hospital. We take them to the cath lab. Average length of stay might be 4 days or so in the US for a run-of-the-mill STEMI. Over that 4-day hospitalization, we think nothing of it, of starting aspirin, P2Y12 inhibitor, statin, ACE inhibitor, beta blocker, MRA. It is in the culture of acute MI medicine to start simultaneously or in rapid sequence multiple medications during an index hospitalization. Then in sharp contrast, you take the US patient hospitalized for worsening heart failure. They're also with a median length of stay about 4 days. But what's our approach for them? Really a diurese and discharge mentality. And the data would say there's few, if any, initiations or escalations of life-prolonging therapy on average. And that's despite the average patient hospitalized for worsening heart failure being on average, much higher risk than the patient hospitalized for acute MI. But even though I would always say, well, there's no obvious proven risk of starting multiple medications at once in terms of increased intolerance or side effects, and we talk about the risks of omission all the time and delaying these therapies that work very quickly, people really still didn't take my word for it very much. But then, lo and behold, in 2022, we had the STRONG-HF trial, which was now a direct randomized clinical trial body of evidence, testing simultaneous rapid sequence initiation optimization of GDMT for patients hospitalized for heart failure versus usual care, the serial, slow, one move at a time approach. And again, this was an international clinical trial, more than 1,000 patients randomized. They were followed for the primary endpoint of 180-day heart failure readmission or all-cause mortality. And again, this was a one-to-one randomization to rapid sequence, simultaneous in-hospital initiation and aggressive post-discharge optimization versus discharge the patients on what you normally would, follow up as you normally would, start medicines as you normally would. Well, one of the most impactful headlines that came out of STRONG-HF was that the study was terminated early by the Data Safety and Monitoring Board because it was deemed no longer ethical to continue to randomize patients hospitalized with heart failure to usual care. There was an overwhelming benefit with simultaneous rapid sequence optimization that it was deemed no longer safe to continue the experiment. And As you might expect in strong HF, the patients that got in-hospital initiation with rapid sequence simultaneous optimization of GDMT, much higher exposure to GDMT over post-discharge follow-up than those who got usual care. But what did this exceptionally high GDMT exposure buy us? Well, again, it bought us an overwhelmingly positive clinical trial. When you look at the primary endpoint, 180-day readmissions for heart failure or all-cause death, 34% relative risk reduction with rapid sequence simultaneous optimization. This led to an enormous absolute risk reduction of over 8% to prevent one death or heart failure hospitalization over 6 months, a number needed to treat of only 12. But it wasn't just about hard clinical outcomes. The patients also felt better with rapid sequence simultaneous optimization of GDMT. There was also improvements in congestion status, incremental lowering of NT-proBNP, incremental improvement in NYHA class. And for those that were so worried about the safety and tolerability of how can we possibly start more than one medicine at the same time and make these aggressive medication changes, no significant difference in serious adverse events compared with
Dr.
usual
Green?
care. Yes.
Hey, there's a question in the chat that I'm going to read to you.
Oh, perfect.
Do you recommend starting all 4 pillars of treatment with a SBP 110?
So in the in-hospital setting, the patient's hospitalized for heart failure, they need to be prioritized in all 4 by time of discharge. You know, we could talk about they all need to get it on the same day. I'm not that much of a stickler for all 4 initiated right away on the same day when they're in the hospital, because again, they're going to be in the hospital for a few days. But in the hospital, the most important thing that matters is they go home on all 4 of those therapies. So what I encourage people to do is, average length of stay is 4 days. We get focused on diuresis right from the get-go when the patient's in the ER and everything. We think about decongesting the patient, but right away we need to think about what's the GDMT plan going to be? What's going to be the strategy for getting these patients on optimal GDMT so when they are ready to leave 4 days from now? So again, we can do things simultaneously with our decongestion, is that to add GDMTs, and definitely it's okay to start more than one medicine on the same day in the hospital. Things like SGLT2 inhibitor and MRA, for example, get along great. One decreases risk of hyperkalemia, the SGLT2 inhibitor. One increases risk of hyperkalemia. Both have additive decongestive properties. So again, think about the GDMT from day one when you're taking care of your patient hospitalized for heart failure. Hopefully that answers the question.
Okay, another question just popped on.
Sure.
Would you recommend discharging on a diuretic such as Lasix in addition to GDMT at discharge?
So most patients hospitalized for heart failure do require some dose of loop diuretic. So I want to be very clear. I am not saying don't use loop diuretics. And again, remember that perfect world. In a perfect world, every patient would be euvolemic on appropriate dose diuretic and they would be on GDMT. But the bottom line is diuretics don't make patients live longer. They're like a Band-Aid for the underlying problem. It's like treating a broken bone with a pain pill, right? The pain pill doesn't fix the broken bone. It helps the symptoms of the broken bone in the short term, but the long term is you need a procedure that's going to heal the bone. And by analogy, that's our GDMT. That's the chemotherapy for the heart. The diuretic you want to use as little of it as you can get away with. Again, Transform showed that, again, when we have escalated diuretic therapy, if anything, we're ramping up the neurohormonal axis, all those things we're trying to block with our GDMT. So my mentality is definitely when push comes to shove, you want to prioritize GDMT. And sure, get your patient out of extremis. Don't leave them floridly volume overloaded. Try to get them as best you can. But we need not obsess about getting the patient completely without edema, completely normal JVP, if it's going to mean that we're sacrificing our ability to have the patient on GDMT.
Okay, we have another question. We love.
Great.
Okay, this is more of a social issues question. How do you manage patients with new onset heart failure now having to start 4 new medications that may have significant costs and may not be able to afford them?
So it's a great question. So the first thing I'll say is that SGLT2 inhibitors and ARNI now for our Medicare Part D patients, there's the Inflation Reduction Act, which theoretically it's supposed to start this year, where out-of-pocket costs for our Part D patients should be capped at $2,000 for the entire year for all their medicines. So that's like $167 per month. So again, I'm not saying that's cheap, but it certainly seems like there's now hopefully a ceiling of how high the out-of-pocket costs could potentially get for our Medicare Part D patients. The bottom line is, in hospital, we generally have, for these branded medicines like RNA and SGLT2 inhibitor, we generally have more resources, more manpower to submit things like prior authorization, to do everything we can to leave no stone unturned for trying to get that patient access to medicines. So I encourage the in-hospital teams to try to do the heavy lifting with it, trying to explore the patient assistance programs and all these other things. Because again, these patients hospitalized for heart failure, these are our highest risk patients. They need all the help they can get. And we owe it to them to do our due diligence. That's another reason why not to wait until the day before discharge to start thinking about GDMT. If we think that SGLT2 inhibitor, for example, is going to be expensive, I want to start thinking about that on day one while the patient's getting diuresed. Don't waste time thinking about how we're going to get that patient on GDMT, even if they're not ready for discharge for a few more days. Use that time wisely is my advice. I'll also show a slide later that although we like to talk about the costs of medicines and everything, and they're absolutely a barrier for select patients, I will show later that they are by far not the costs for the patient out of pocket are not the dominant reason why we have widespread systemic use of GDMT, because even our generic medicines that are really cheap as dirt, we don't use them to a high degree. And I'll show some of those data in a little bit.
Okay, we just got another question in. How is heart failure related to lower extremity edema?
So shortness of breath and edema through volume overload are like the hallmark symptoms of worsening heart failure. So by far, the majority of our patients hospitalized for heart failure, they're going to have one of those two things: shortness of breath or pulmonary congestion on X-ray, or lower extremity edema. Essentially, the filling pressures in the heart elevate, and this essentially, when the right-sided pressures increase in the right ventricle and the right atrium, it causes fluid to back up into the IVC, into the lower extremities. So that's how it's like mechanistically tied together.
Thank you.
All right. Well, this slide here builds off the topic of, well, again, how are we going to prioritize GDMT, especially branded medicines? People are in the hospital. These are data from a trial of sotagliflozin, which is an SGLT1 and 2 inhibitor that's approved for use for heart failure. But patients hospitalized in this clinical trial, the SOLOIST WHF trial, at discharge, either went home on placebo or the SGLT inhibitor. The SGLT inhibitor cut the risk of 30-day and 90-day post-discharge events in half. It cut that risk in half. So when I'm talking about doing our absolute due diligence to make sure our patients go home on an SGLT inhibitor and all the other appropriate medicines, this is what's at stake. I don't want to be on the placebo arm if it's me with a patient hospitalized for heart failure. I want my team to do everything they can to get me the therapy that puts me on that blue line that's still very elevated, but a lot lower, half as high as the non-SGLT inhibitor group. And then I'll also go back to, again, I'm not bashing diuretics, but just by comparison. Sure, euvolemia is great, but I don't care what you do with your diuretic management. You think you have the perfect clinical exam and perfect dose of diuretic for that patient, no matter what you do, no diuretic management strategy is going to cut that risk of the patient coming back to the hospital or dying post-discharge in half. Absolutely none. So that's why when push comes to shove and we're saying, okay, I got a blood pressure of 100, the patient has a little edema left, but they're also not on, a RAS inhibitor. What am I going to spend my low blood pressure on? Just pick the RAS inhibitor. Leave the edema alone. Don't make the patient hypotensive with diuretic. Leave the tank a little full if it means you're going to get them on an ACE/ARB or ARNI, for example. And I talked earlier about this idea of risk of omission, because so often in medicine, we're thinking about, first do no harm, and we think about risks of side effects whenever we're starting medicine and risks of intolerance. But the reality is that we have such a robust evidence base with our GDMT that we need to think about the risk of not starting these therapies. That's an evidence-based risk. The risk of not starting a GDMT and the patient meets eligibility criteria, risk of higher chance of dying, higher chance of going to the hospital, higher chance of deterioration of quality of life, and higher chance of worsening symptoms. Those are the evidence-based risks of omission. And, I'll just put this another way, like, let's say someone has an eGFR of 40 at discharge. Now, that's well within the eligibility criteria to start an MRA, a very inexpensive therapy, yet the majority of patients don't go home on this therapy. So eGFR 40, people say, oh gosh, I'm a little too nervous. It seems like it might not be safe to start this with someone's kidney function that way. I would argue it's not safe to discharge a gentleman like this without an MRA. It's about strategizing your thinking, contextualizing your thinking. Again, discharging someone with an eGFR of 40, but they're eligible to receive a medicine that reduces the risk of dying and going back to the hospital. Discharging the patient without that therapy, I would argue, is not safe. So again, this idea of first do no harm, it's a matter of perspective. So to summarize, proper management of patients hospitalized for HFrEF in 2024 here, I need to update the slide now to 2025. I'd argue 3 simple steps for our HFrEF patients. Priority number 1 is to initiate at least a low dose of ARNI, beta blocker, MRA, SGLT2 inhibitor. That's priority number 1 at discharge for our patients hospitalized for heart failure. Once you achieve priority number 1, then we can focus on titration of beta blocker as tolerated and titration of the other therapies to the target doses. But priority number 1 is priority number 1 because in those event curves that I showed you with the very early separation of those clinical trials, that's happening when we start the low doses. So don't discount like, oh, carvedilol 3.125, it can't be that important. There is major benefits on heart clinical outcomes even when we start low doses of medicine. So try to achieve low doses of all 4. There's only 1 dose of SGLT2 inhibitor. And then for our patients with heart failure with an ejection fraction above 40%, these are called mildly reduced or preserved ejection fraction patients. Priority number 1 is not a little different with the medical therapy, but we still need to have this idea of simultaneous rapid sequence optimization. Here we have really 3 pillars of therapy: SGLT2 inhibitor, MRA, preferentially nonsteroidal MRA finerenone if possible, and GLP-1 receptor agonist if obese. I did not have time to get into the data for all these different therapies for HFpEF. This is a rapidly evolving space. But again, same concept of in-hospital or early post-discharge initiation for all these therapies for HFpEF is exceedingly important. Then, this is my second to last slide. Someone asked about the costs. And, I mentioned that, again, of course, we've all seen it for our clinical practice. I do not want to dismiss the importance of out-of-pocket costs for certain patients. It is absolutely a barrier, and I've been frustrated with my own practice for some patients. But I think this conversation about out-of-pocket costs disproportionately hogs the attention as the excuse why patients are not on GDMT, when in fact it is not the dominant reason. We look at data for real-world use of patients hospitalized for heart failure at time of discharge. And on the left-hand side, you see quad therapy in the United States. Less than 1 out of 10 eligible people are going home on quad therapy. And this is where people say, oh, well, it's because SGLT2 inhibitors are too expensive and ARNI is too expensive. So no surprise, only 1 out of 10. Well, what about the purple? The purple bar, this is patients going home on triple therapy. And this is even with 3 generic, cheap as dirt medicines: ACE-ARB, beta blocker, MRA. Cost is no excuse. Median out-of-pocket costs for an entire year for these therapies, $160 a year, about $12 to $13 a month. 3 all-cause mortality reducing medicines. And again, less than 1 out of 3 patients even receive this really cheap as dirt medication regimen. You compare this cost for this cheap as dirt life-saving medication regimen to the cost of a newly approved cancer drug, which is about $283,000 per year a couple of years ago. So again, it's night and day oncology versus heart failure care, but we need to not use cost as a reason why we're doing such a bad job implementing life-saving therapies for our heart failure patients. So to summarize.
Hey, Dr.
Of
Green.
course. Oh, go ahead.
Got another question. Sorry to interrupt you.
No problem.
So excellent presentation thus far. Can you please comment on the utility need to trend a pro-BNP in the hospitalized patient with decompensated heart failure? Thank you.
Yeah, so NT-proBNP is almost universally checked at admission, a lot of times sent in the emergency room. So we have that, and it's, very elevated. A lot of times patients are full of fluid. It is in the guidelines that we can do a pre-discharge NT-proBNP to, risk stratify our post-discharge prognosis for these patients. And I do check it, not all the time, but pretty regularly in patients where I'm concerned, where are they standing with their decongestion status, and how far do I have to go if their volume test is hard to tell? It gives me another perspective. So I think it's certainly a reasonable thing to do for a lot of patients, although it's not necessarily clinically necessary for every single patient, and the guidelines don't give it a class 1 recommendation. It's class 2 for the pre-discharge NT-proBNP. So hopefully that's some food for thought. All right.
Thank you.
Well, this is my last slide, and I'll summarize, and I'll turn things over to my good friend and colleague, Dr. Fudim. So again, take-home point. I'm not saying don't use diuretics. I'm not saying leave the patient floridly volume overloaded and discharge them that way. But we got to keep our eye on the prize and recognize what's the top priority. And for the patient with HFrEF, the top priority among all else is we have them on 4-pillar GDMT if they meet the eligibility criteria for each of the individual medicines. And for our patients with heart failure with an EF greater than 40%, the top priority are SGLT2 inhibitor, MRA, and GLP-1 receptor agonist. If issues with low blood pressure, tenuous kidney function, or poor tolerability, these are the things that give us stress when we're taking care of patients hospitalized for heart failure. If you're having to choose between escalating diuretics and chasing euvolemia versus adding that extra pillar of GDMT, the choice is clear based on the clinical trial data. You want to try your best to, of course, achieve both euvolemia and optimal GDMT. But assuming the patient is stabilized and out of extremis, I urge us not to sacrifice GDMT for the sake of increasing diuretics. When it comes to congestion status, great is, of course, great, but good is often good enough. Whereas for GDMT, good is not good enough. It needs to be great because there's substantial risks of omission if even we omit even one of the pillars that a patient is eligible for. So with that, I'll take any further questions, and I'll turn things over to Dr. Fudim and team. Thank you.
Any final question? And Dr. Green's going to stay on the call with us till the end. So if something comes up in your mind, we can circle back to him after Dr. Fudim. Dr. Fudim, if you'll go ahead and bring up your slides, I'll give him a little introduction for you.
Dr. Moore, can I interrupt and just read the last question that's in the chat so that it doesn't get missed? Thank you. Just wanted to touch back on the kidney function and discharging on the 4 pillars, as it can be tricky. Starting these medicines on inpatient side, given eGFR can be a moving target, especially with patients coming in with kidney injury. Wanted to get your thoughts on managing that situation.
No, it's a great question. And again, this is one of the things that give us stress. It's kidney function and blood pressure are the top 2 stressful things. So from a kidney function perspective, first of all, there is absolutely no concern with SGLT2 inhibitor. So that's one of the pillars. Absolutely no concern. So as long as the eGFR is at least 20 on a given day, it's a fine day to start an SGLT2 inhibitor from a kidney perspective. If the eGFR goes below 20, the clinical trials then would continue the SGLT2 inhibitor up until the point of dialysis, heaven forbid. So the SGLT2 inhibitors, you have to remember, are not kidney toxic. They are the kidney's best friend. There's dedicated kidney trials which show they decrease mortality and hospitalization risk among kidney patients. And they also have additive decongestion function. And they also lead to, over time, less need for diuretics in many clinical trials. So SGLT2 inhibitors, absolutely no concern whatsoever when it comes to kidney function. Now
we have one last.
Oh, go ahead.
No, I didn't mean to interrupt you. I'm sorry. We just had one last question that's going to slide in. What diagnostic features?
Wait, Mary, let's let him finish the other question.
So I was going to talk about the MRA is another thing that we think about with kidney function. So technically, by the guidelines in clinical trials, we should not be initiating MRA therapy, like steroidal MRA, like spironolactone with an eGFR less than 30. But if your GFR is less than 30, greater than 30, so again, that patient with an eGFR of 35 or 40, that maybe makes us nervous. But from an evidence-based perspective, they are eligible for MRA, and we need to have the courage. We're so worried about, provoking hyperkalemia and worsening kidney function in that patient. But the reality, and we're saying it's maybe not safe to start it with an eGFR of 40, even though it's just kind of not evidence-based. It's really, again, the answer is it's not safe to discharge the patient with an eGFR of 35 or 40 without MRA, because again, it rapidly reduces risk of death and hospitalization. So it's about, where's the, your risk of omission and perspective. If we cause hyperkalemia, we feel bad about it, we blame ourselves. But if patients go home and die, the truth is we blame the disease a lot of times. And we're like, oh, nothing I could have done, that's heart failure. No, I mean, there was something we could have done. We could have discharged them on a therapy that was proven to reduce the risk of dying. So I think we need to take it seriously when we think about the risks of omission when it comes to kidney function and blood pressure, and just try to stick to the bread and butter eligibility criteria and muster some courage, I'll say, for lack of a better term.
Mary, is there one last question? We need to get Dr. Vadim going here.
Just one last question. I apologize, Dr. Green, for cutting you off earlier.
Oh, no worries.
What diagnostic features do you use on the echo to diagnose HFpEF
maybe?
Yes. In my experience, HFpEF is a fairly underdiagnosed condition.
Yep. So absolutely. I mean, HFpEF is challenging to diagnose because, it's inherently defined by a normal ejection fraction in many cases. HFrEF kind of hits you over the head with a diagnosis. You get an imaging test. It says low ejection fraction. The alarm bells go off. It's pretty obvious something's abnormal. And if you're not an expert in it, you refer them to an expert right away. But HFpEF comes back with a normal ejection fraction and kind of subtle findings on echocardiogram and other imaging. So NT-proBNP can be helpful. It's not perfect. There's about a 20 to 30% of HFpEF people that have normal NT-proBNPs, but it's a whole lot better than not checking it for diagnosing HFpEF. The other thing I'll highlight is that HFpEF is often easiest to diagnose in patients that are hospitalized for heart failure, because that's when things are really magnified and really the horse is out of the barn. So the patient has like clear volume overload symptoms, pulmonary edema on chest x-ray, lower extremity edema. That in the setting of a normal ejection fraction, 95 out of 100 times is true garden variety HFpEF. It can be subtle if someone has no edema and they're seeing you in the outpatient, they're just saying they're short of breath and everything. But the in-hospital HFpEF is really the easiest time to diagnose it.
Okay, thanks so much, Dr. Green. Tremendous discussion. Excellent. Well, let me introduce to you Dr. Vadim, who's ready to talk with us about heart failure, if you will, monitoring devices. He received his MD degree from the Heinrich Heine University in Germany, and then his medicine residencies were completed at Vanderbilt in Nashville. He then came to Duke for a series of cardiology fellowships, an innovative physician fellow, and then finally a Duke clinical research fellow. He also received his Master's of Health Science degree at Duke while he was there. He is extremely well published with over 270 publications in peer-reviewed journals, 6 book chapters or editorial roles, and he holds 10 patents on devices that are utilized in heart failure management. He's received numerous awards, both for teaching and also for his research efforts, both as a fellow and as an attending physician at Duke University Medical Center. So we're delighted to have him talk with us. And Dr. Vadim, the floor is yours, my friend. Thank you.
Thank you so much. I am impressed that people are staying on so late. 84 of you all on the call. I appreciate Dr. Green making actually laying the great ground for what I'm going to be talking about. I'm going to repeat a little bit of what he said as a test to see if you guys listened, because there's no way to avoid talking about, of course, the landscape of heart failure, which is I always say is going to be the challenge for our generation, because heart failure related mortality. So the amount of people dying of heart failure in the US population as measured by the cause of death given on a death certificate being named heart failure was going down over the years 99 to 2010. We made great progress, and that was the drugs that were just mentioned, ICDs, and whatever else was contributing to the benefit. But then over the subsequent 10 years, 2011 to 2021, all the benefits, the mortality associated with heart failure was now going up, actually undoing all the benefits we had. Yes, COVID was contributing to it in the last few years, you're seeing on the right side, but that was not what, contributed to it in the majority. That trend got reversed, likely as a result of decade-long contributing comorbidities that are really fueling heart failure to date. And it's, the obesity crisis, the diabetes crisis, the uncontrolled hypertension. I could go on and on. Two interesting things relevant to you all. On the top right, you see that patients under the age of 45, for the first time ever, had an increase in their heart failure associated mortality. They never experienced that before. It was a flat curve for the decades before. That's why we see a number of patients that are younger than 45 on the floors. We just didn't have that decades ago. And then speaking of rural America, you guys are rural, we are rural. If you're in rural America, your risk of dying of heart failure is 30% higher. 30% higher than living in an urban area. So Charlotte versus your area, Charlotte versus Hillsborough, where I live, boom, 30% higher risk of death. So now you heard Dr. Green talking about comprehensive heart failure care. I will completely agree with that. It's imminently important that we titrate it as fast as we can, standardized, protocolized, no room for opinions and for delays. The reality, though, is that even if we titrate those medications, we have to understand that the battle is not over. It's really about maintaining medications and think of additional ways to maintain medication and to improve heart failure symptoms and outcomes, because patients after GDMT is titrated still remain symptomatic in 60 to 70% of cases. And unfortunately, the few things that are left to be done that we do these days is consider comorbidity management. GLP-1 RAs were mentioned, so Ozempic, tirzepatide. You will manage comorbidities where you are able. Diabetes, you got to manage diabetes. Even as a cardiologist, believe it or not, we do a lot of that care. Remote monitoring is one of the emerging things that allows us to manage comorbidities and guideline-directed medical therapy outside of the doors of the office to prevent the inevitable transplant LVAD, which, by the way, will really be an eligible population for that is less than 1% of all patients with heart failure we're seeing. So even though many doctors are trained to do transplant and LVAD therapy, that is just not applying to the vast majority of patients you and I will be seeing in clinical practice. So we saw this. We want to titrate all 4 pillars of GDMT, non-negotiable. We got to get them up. They reduce morbidity, so heart failure hospitalization burden, and they reduce mortality. But here comes the kicker. Colleagues from Stockholm and partnering universities have published data here, and I'll let you just focus on the right column where it's US data. Now they look not only that we didn't get patients on the right medications I heard earlier, now it's about how long did the patients actually stay on the medications once they were titrated in the US, UK, and Sweden. So if we just focus on ourselves here on the US on the right side, you will see that anything that turns red, we start from left to right, is the onset of maximum titration for that specific drug, here ACE, ARB, beta blocker, etc. If you see more red coming from left to right, is that over subsequent 12 months of follow-up, your discontinuation of treatment, or as you see in the other colors, decrease in doses. In short, 50% of patients that were on a medication at baseline were off that medication 12 months. So not only are we not able to get the medications on board, once the medications are on board, we're actually going to lose that battle because half of them are going to discontinue at 12 months. It's not that they didn't want to. It's not that I couldn't afford the $4 ACE inhibitor. It's just side effects, inability to tolerate low blood pressure, AKI, etc., etc., etc. So there's many reasons, obviously, that patients can't tolerate it. So now the real disaster coming our way is actually heart failure with preserved ejection fraction, or HFpEF. That's patients with a squeeze of the heart, ejection fraction of 40 and more. The interesting thing here is that when we apply trials criteria or drugs from the HFrEF space, we really had no success till drugs such as SGLTs came around, weight loss drug came around. These are the only drugs that have helped so far in the HFpEF population, which makes about 60% of all heart failure patients. If you ask yourself, I'm a young trainee, I'm on a call at 8 o'clock listening to this guy with a funny accent, what should I do in the future? What will be the next big thing to tackle? It's HFpEF. Very, very simple. It's going to be the majority of disease, the number one cost driver in the healthcare system going forward, period. 1 million heart failure hospitalizations, 60% of which are just due to HFpEF. All right. So we now know, and I'll skip this because we had a very great job done by Steve talking about the need for disciplinary approach to titrate GDMT. It's not a one-man show. It needs to be protocolized. As a matter of fact, I would argue titration of GDMT needs to be taken out of the hand of cardiologists, needs to be maybe even taken care of the hands of general cardiologists or primary care physician. These needs to be just protocolized by pharmacists, nurses, because there's actually nothing complex about GDMT titration. It's very important to follow protocol. And here comes the kicker, have dedicated time to titration. The reality is that even if we titrate all the GDMT on all patients, we will have a still very large residual risk. Even if you take the most contemporary 4-pillar therapy applied in a clinical trial, the residual risk here shaded in blue is overwhelming and large. We are not done just because GDMT was titrated. It's about maintaining GDMT and considering additional therapies I will not be able to talk about today, but what I want to talk about today is actually how we try to keep people out of the hospital by providing care to them remotely, watching them remotely, but also titrating medications remotely. And the way, and it's hopefully complementing what Dr. Green was talking about, is that our goal is, of course, to prevent hospitalization. That's being the number one cost driver. We focus a lot on weight gain and symptoms. We give patients scales, weight scales, and say, if you're more than 3 pounds up, 4 pounds up, call us. Call us when you're short of breath. That has been tested and is an inefficient and unsuccessful way to keep people out of the hospital because weight gain occurs very late in the disease course preceding hospitalization. We really need to look at biovitals, so to say, much earlier in the progression of heart failure decompensation, such as pressures and heart rates and impedance. There's million things you could measure in a human being that is better than weight gain to try to identify decompensation way earlier. Before the train has left the station, we cannot reverse that process. It's very important to understand that once a patient goes home, the most likely cause for the most likely predictor of rehospitalization is the fact that they had a hospitalization before. So the 30 to 90 days following a heart failure event are actually a very, very high risk for rehospitalization, referred to as vulnerable phase. All hands on deck to try to titrate GDMT and to monitor the patient or see them as frequently as you can in that phase. Now, of course, our society has no bandwidth to see patients in that frequency. So now the one point that I'll make is that STRONG-HF, the trial that Dr. Green talked about, where rapid titration was compared to a slow titration, that trial, and this is very important, required patients to be seen at week 1, week 2, week 3, week 6, if I'm not mistaken, so 4 times in 6 weeks. Who on this call, now I cannot just do an imaginary hand raise, who on this call is unable to see their patients 4 times in the first 6 weeks after hospitalization? I raise my hand. There's no way. There's no way, Jose, you can see a patient 4 times and follow up in 6 weeks. It's simply not grounded in reality. In a clinical trial, it worked. Throw resources and money at an institution, have research staff, that will work, but not in clinical practice. And this is where remote patient monitoring comes in. Now, interestingly, we think of remote monitoring in many cases, and that's how I thought about it when I started with this, as a diagnostic opportunity to watch patients. We've got to monitor patients. Why do we think of that? Well, there's a lot of tools, invasive on top and non-invasive, patches, vests, implantable toys you can put into the pulmonary artery, in pulmonary artery toys you can put it into the vein. I mean, anything you can imagine, as invasive and non-invasive as you can do it. By the way, half of these devices I'm showing you are already on the US market approved. Half of these technologies I'm applying on my patients as is at Duke University. The problem is what's in the middle, this lady and this computer. It's not the implants or the device we put on the patients. It's what the data production is by these devices is overwhelming. There is minute by minute, hour by hour data generated by these devices. We have no bandwidth to watch these technologies either. And we need to watch it and synthesize the data and give the data in a digestible manner to this treating provider that then can act on it. So it's very important because data you don't act on is worthless to the patient, the doctor, and the healthcare system. So I'm just going to give you examples of how the remote monitoring, just the monitoring space has evolved. Now there's two classes of monitoring tools. There's the pure gadgets. I give you a cuff and a blood pressure. It gives you raw data. You act on the data, you look at the data, it's all up to you. AKA blood pressure sent our way, weight sent our way. Now that is very, very raw, a lot of data that we tend to have trouble digesting, particularly if it's being sent to us in weekly downloads, daily downloads by patients. That has evolved to where if you want to manage large populations, that you're only going to get alerted when a threshold is crossed, only when 4 pounds of weight are gained, only when the blood pressures reach a certain weight, only when the pressure in the lungs on the CardioMEMS devices reaches certain pressures, you will be alerted. That is where we have gone. Now there's a filtering system. Now I can monitor instead of 10, 15 patients a week. Now I can monitor a couple hundred patients a week because I have a filtering system in place. Now, what are the gold standard technologies out there? The gold standard that we have, which is expensive, not available at every institution, but we have it at Duke and UNC has it as well. I just talked to Dr. Volz earlier today. It's the so-called CardioMEMS system. It's a pressure sensor you plant on the right pulmonary or left pulmonary artery. This goes right at the left pulmonary artery. You can implant it via the neck vein or the groin vein. The key data are actually buried. Sorry, I have a sensitive mouse here. The key data are buried here. If you look at 3 pooled data using pressure-based data in treated patients versus control patients, there was a reduction in 25% at 1 year of mortality and 36% of rehospitalization. So these technologies, no doubt, might be expensive, might be invasive, but if you watch that data compared to controls that had that device implanted but not watched, you have a significant and clinically very relevant reduction in heart failure hospitalization. Now, currently, the guidelines give it only a Class 2B indication. This might improve to Class 2A in the next set of guidelines. We will see. Now, other technologies that we use at our institution that are non-implantable are these patch-based solutions. Just one example of what we are using. These are patches you can apply upon discharge and place into the axilla. Patients that have been tested in this in the study called BMAT trial, they actually gave one population the patches and just watched them passively. One patch population got it, and what was watched actively. They looked at event-free duration for 90 days. So they wanted to see, can they keep people out of the hospital? And they were doing so more successfully here in blue in the treated arm versus in black in the observed arm, with a 38% reduction in risk of heart failure hospitalization, time to rehospitalization. So that is a clinically relevant and statistically significant reduction in heart failure hospitalization. So that is non-invasive tools. I talked about invasive tools earlier. Another set of tools that is available and often unrecognized is that all implantable defibrillators on the US market, no matter what brand they are, have some form of implantable technology in them. And one of the most popular ones that has a dedicated remote monitoring technology built in is actually the so-called Boston Scientific HeartLogic device. It has 4 biosensors that are activated that measure heart sounds, just like you would listen with your stethoscope, but it's a lot more sensitive. Respiratory rate, lung impedance, thoracic impedance, it measures how much water you have in your lungs, and the activity level. Interestingly, each of those sensors by themselves, if they would go array, would indicate a higher risk of mortality and morbidity. But now are getting combined and put through a machine learning algorithm. The machine does it automatically, the defibrillator, and spits it out to indicate a so-called alert status. The higher the alert status, the more likely you're going to be decompensating. And it goes from right down here to the left 40. But around 16, that's a pre-programmed device. If your HeartLogic score goes for above 16, you are in alert status. And what does it mean to be in alert status? It's a unitless value because it's a composite of a number of scores, of a number of sensors. First of all, it's highly sensitive to decompensation. It indicates if the alert is up that it's 70% chance you're going to get hospitalized in the next 2 to 3 months. A. B, it's actually quite sensitive, meaning you have very few false alerts in patients. And key part is that these sensors are so sensitive that it identifies the decompensation event in average 34 days before you get hospitalized. So if you would not act on an alert above 16, your patient would be in a hospital in an average 40 days out. So that is how sensitive it is, that you have about a month in average before the patient lands in a hospital. And that's very, very important. We do not have to overreact when these sensors ring because they're so sensitive and so future looking. That is a benefit, but also a curse of these technologies at the same time. We can talk about it maybe later in the Q&A. If you're in alert status versus not being in alert status, you have a 10 times higher rate of hospitalization. That's what it means if you express this in other terms. Your risk of being hospitalized if you cross the threshold of 16 is 10 times higher in the next 90 days if you're not. If you now on top of that add NT-proBNP, say, listen, it's great that you're on HeartLogic alert status. By the way, we have over 1,000 patients in the Duke system that we are watching across the state with this technology. Just to give you a dimension of patients we watch on a weekly basis. Now, if we add an additional biomarker, and let's say the NT-proBNP is elevated versus NT-proBNP is not elevated, and that uses a threshold here, 1,000. Now you have 50 times higher risk of being at risk for hospitalization the next 90 days as compared to not. So you can, of course, add additional risk biomarkers, and you don't have to rely on a sole electronic biomarker, but these tend to be very, very good biomarkers. So I'll tell you what, Jesus, my mouse is sensitive today. So I'll tell you what my favorite study is using this technology. This is actually just to show you clinical practice. This was a study that was actually run by Adrian Hernandez from Duke, and it's called Manage HF. Actually, Duke was a site. I was participating in the study as a site. Look at the figure here on the left. Each of these columns is a hospital in the United States. There were a total of 20 hospitals that enrolled up to 200 patients. They had implanted ICDs, and I just watched them. And when in alert status, the site was activated, an alert that somebody's going alert status, and they were provided instructions how to act. Go titrate GDMT and titrate diuretics if you can. First of all, let's look at the colors. Dark blue indicated that diuretic was the choice of action when the alert went up. And that's what we're seeing in remote practice. If your patient calls you also with weight elevation or symptoms, you typically titrate diuretics first and not GDMT, which, as Dr. Green explained, might actually be a problem that we are so diuretic focused. But that's just an observational study. That's what happened. In 70% of cases, diuretic was titrated first. And then magenta, your diuretics or non-diuretics were titrated, aka GDMT. But what is interesting is the white space. The white space outside of those bars indicates that patients were alerted, here 100% of alerts, but white space indicates inaction. So the center all the way on the left that has a completely white bar, I need to meet this PI. I need to meet the doctors at that site because they had zero action on all of their alerts. Look at the center on the right. They had 100% of action on all alerts. So I don't know which center I was. They didn't disclose it, but I certainly would hope that our institution was all the way on the right or further on the right because you certainly want to act on alerts. Why? Well, inaction is bad. How do we know? If you did not act on these alerts, this is in red, you took longer time to be decongested. If you take this as a congestion index, the HeartLogic score, if you acted, you're in blue, you were faster to get out of that HeartLogic index from a high value to the low safe zone. Also, if you acted on patients, your risk of rehospitalization was a quarter of that prior to the initiation of the study because we track hospitalization burden pre to post. So it's very likely that action is going to result in lower hospitalization. This has yet to be confirmed in a randomized fashion. So I'm going to give you now a real world example of how we do that in clinical practice, just to demystify and take the magic out of this. I have a nurse and a PA that are working on that on a weekly basis. We have several thousand patients in the system that we are watching. HeartLogic is just one of the system. We have the implantable pressure sensors in the lungs. That's PAs, the CardioMEM sensors. We have patches. We have scales. You add up, it's going to be a couple thousand. So this is how it works. There's a dedicated day on Monday where we only look at the ICDs. If you are found to be in alert status, which by the way affects only, I repeat, affects only about 50 out of 1,000 patients are in alert status. When I throw around big numbers like 1,000 patients, most patients with heart failure are not at risk of imminent decompensation. It is a very small part that is at risk of decompensation, less than 5% that you need to pay attention to. But that's how you can manage your resources and allocate them only to the patients at high risk. That's where remote monitoring comes in to help you out. What do? We review that chart, find out if there's anything going on if just from the chart alone or phone call to the patient that would be reversible. What do we find in 50% of cases? Non-compliance. They went on vacation, forgot their meds. They have a new boyfriend, new girlfriend. They have been eating out a lot. They forgot to, restrict the salt intake. They didn't take the GDMT. That tends to be one of the most common causes. If there's no reversible cause, we ask them to titrate diuretics for up to 3 days, and we're going to revisit them in 7 days. Again, we look once a week. No need to panic, ladies and gentlemen. Why? Because I just told you that our sensors ring 1 month or 34 days in median ahead of decompensation. We have a lot of time. If the score in 1 week is going down, now it can be a CardioMEMS pressure sensor that indicates lowering of pressure, good. The HeartLogic score is going down, good. If that's going down, we leave them alone. If the score is not improving in orange, we actually recycle this. We go back in the loop and we ask them questions. And last but not least, here in red, if the score is going up, despite us having taken action, contacted the patient, have done education on the phone, by the way, all done by my nurse and or PA, now we have a problem. We tend to, in these cases, ask the patient to come in for an in-person visit because now we're maybe a couple of weeks into this process and we don't want to lose track of it and be too late. Now we have also increasing amount of tools that we can deploy in the ambulatory setting. We are no longer restricted to doubling of oral diuretics. Guess what? If you to be congested in the outpatient space, your gut is congested, those oral diuretics you want to increase might actually no longer work. We now increasingly deploy subcutaneous Lasix, which is an equivalent of 80 IV Lasix that you can get shipped to your house, multiple cartridges. You take it out of a package, you slap it on your chub and push the button and infuse it over 4 hours. Now, there are other solutions coming on the market that are either inhaled solutions or injectable solutions that are going to be no longer need to be injected over 4 hours. But there's a lot of things that are coming down the pipeline because the government, the industry, and we as clinicians are realizing if we want to keep people out of the hospital, we need to provide them the opportunities to treat them and monitor them in the outpatient setting rather than be so hospital-centric. And that is just to show you what my panel looked a couple months ago. I had 914 active patients. We have now 1,000, 51 of which were in the alert status. So I have only to pay attention to the 51 patient, not to 914. But guess what? Topic for another day, but we bill for all 914 patients. You're allowed to bill because I'm watching all of these patients, whether they're good or bad cases, doesn't matter. It's all billable. This is how we maintain and pay for the staff that we need. So some Duke internal data, this is a little bit outdated. This is now over a year old. But when we started our first CardioMEMS patients, we're up to over 100 active patients that are alive in the system. We have a 75% reduction in rehospitalization, pre to post. This is Duke Heart Center data. This is not data that I generated because they continuously are trying to find a reason to shut my program down. But then when they look at the data, they realize, whoops, look, with CardioMEMS, 75% reduction in rehospitalization. ICD, look, 50% reduction in rehospitalization on the first 250 patients we looked at. And again, we had 1,000. So just imagine what that means to your healthcare system if you deploy these type of solutions. I'm telling you, whether you think you have the capacity or not, you will not get around to start doing population size management in the outpatient world. This is a little bit what I mentioned earlier. That's the strong HF data that Dr. Green presented. Beautiful results. Early separation of curves of high intensity versus low intensity or usual care. We need to titrate drugs as soon as possible. But look at this. You have to see the patient 1 week, 2 week, 3 weeks, 6 weeks per protocol. That's their protocol. They gonna put something of this nature in the next European and US guidelines, as Dr. Green sort of indicated. We got to be aggressive. But how we're gonna be able to titrate is a whole different question. No doubt, after these first 2 talks, for you, I hope, to realize that we have no doubt that we need to get these medications titrated. I'm trying to provide a potential solution for the how that has to be a protocolized approach, In many cases, physician independent, and B, some form of remote patient care might be indispensable. So now I talked about remote monitoring, but look, I strike out remote monitoring. I said, we focus so much on the diagnostic part. What about the therapeutic capabilities, the ability to provide care to patients in a remote setting? Well, here's the data for this. We have evolved from gadgets alone, gadgets that have on the top right filtering systems in place, to all the way at the bottom to where we can now actually also provide treatment support. We have now software solutions, not even fancy artificial intelligence, very simple. If your blood pressure is high enough, your heart rate is good, you can go ahead and double the dose of beta blocker that was pre-programmed by the doctor. You can have now robots pre-program into your iPhone or Samsung phone and titrate those medications. Now that happens on a level with the patient, where the doctor doesn't even get involved. This is done so you unburden the medical staff. On the bottom right, one of the solutions, by the way, in the LifePoint system, multiple hospitals have already deployed the solutions, including soon on the periphery of Duke campuses, where we now partner with other institutions. There are commercial institutions that can flex up nurses, nurse practitioners, doctors, as well as pharmacy techs and pharmacists in a heartbeat. They have hundreds of them on disposal to help you deploy these remote GDMT titration clinics we talked about the last 1.5 hours, in order to scale them and bring them to the remote areas where you might not have the resources. They come with personnel and with tools they can deploy remotely without ever having to touch the patients. More to come. There are many, many, many solutions in this space. Some of the names, the Cadence, the Ventricle Health. I mentioned these names because these are companies that actually have done commercial and research projects with Duke University, and I've actually published some of that data on their successes about getting people on GDMT. So now, Dr. Green mentioned some of the many approaches that we have attempted to get patients on GDMT. There's EMR, so electronic medical record alerts, that tend to be helping a little bit. We can nudge the patients, which helps a little bit. I think all of these solutions are cute. They work on a single 2-center level. They're not scalable. They're not going to be scaled across the United States. They're going to not be introducible across all electronic medical records, etc. We have done a similar project to this Implement HF project that was done at Brigham by actually a former Duke resident, Dr. Ankit Bhatt. And Dr. Green actually has done a similar project out of the Duke healthcare system, where we actually titrated GDMT using virtual consults. Listen, if you think the majority of heart failure patients are on a heart failure service, are not on a heart failure service, but on a medicine service, deploy at least your residents, your fellows, and your cardiology attendings with interest in heart failure GDMT remotely. You do not have to see the patient. I'm repeating myself. GDMT titration does not require an attending level supervision, doesn't even require an in-person visit because it's protocolized. So a number of virtual GDMT programs in the hospital have repeatedly demonstrated that you can increase the uptake of GDMT prior to discharge or at follow-up as compared to standard of care. That's the power that we can have by sitting in our pajamas at 8 p.m. and reviewing the electronic medical record and identifying gaps in care. Now, that is done all by humans. Dr. Green and others are testing right now a system at Duke, and I'm actually a proband, a company called Anumana that is testing some of this. There's now electronic medical records that are getting scoured by software, by AI systems. It's the era of robots controlling our care. Now, I will welcome that, and that's why I'm happy participating in this project, because I don't think that doctors need to review my chart, because robots and AIs can do it just as well, if not better. So now that robot provides me recommendations when to titrate GDMT, where I might have missed something. And in a busy clinician's day, is not a bad idea to have some additional support system to guide me through this. And I bet our data will look just as good as what I'm presenting here, that is human supported. I'll skip this. Actually, I'll go back. When we looked at these remote clinics that are supported by human personnel and low-scale tech, such as blood pressure cuffs, this is analysis of a couple hundred patients out of the Cadence system. You actually could now reproduce multi-state, multi-center level and up titration GDMT, just like I showed you on a single center level. But the key comes here. If you look at the few hundred patients that were done here, or now the data is going to be becoming thousands of patients in capitated healthcare systems, you save an average $1,000 per patient per month if you to have them enrolled in these GDMT titration clinics using these massive scaled human operations. So now like, wait, why would you save so much money if you're deploying resources, titrating more expensive medications? Because, ladies and gentlemen, you prevent hospitalizations. Those drugs make a fraction, less than 10% of the annual budget of the cost of healthcare and heart failure. 80% of the cost of healthcare in heart failure are hospitalizations. If you save one hospitalization, you save the system $10,000s of dollars. Thus, these GDMT titration solutions work so well. In conclusion, comprehensive heart failure care is the name of the game. Got to get those medications titrated. They need to be protocolized. Take the humans out of the equation. So now the era of artificial intelligence is coming, whether you like it or not. The era of remote monitoring is coming, whether or not. We are living in the era of Amazon Prime. Who on this call, raise your hand, is using Amazon Prime to get their food delivered, watch their movies, or whatever you get is delivered through a package? We want our data, we want our drugs, we want our doctor now at our doorstep. We don't want to go to the doctor. That's where the society is going. And I think you will see that the society, our patients will demand, and we will be also more efficient if we not only use AI to review our deficiencies and opportunities in a chart, but if we also deliver care and titration, not just for video visits and virtual visits, but we also allow our patients to obtain care, such as titration visits remotely. Whether that requires a human contact or not, there's many, many opportunities to do that. So I do think that remote patient care is here to stay and will dominate and allow us to scale our clinical operation, titrate GDMT remotely. And, I sort of encourage you to embrace that now, particularly in sight of the labor shortage that we experience across all domains. Thank you very much. That's all I had. I'm open for questions.
Dr. Fadim, thank you so much. The energy, the enthusiasm, super duper do. R2D2 is going to be the guy to go to for this, and it works out real well. Absolutely. Really exciting. Do you have any questions for Dr. Fadim? Anything in the chat, Mary?
No, there's, oh, yes, Dr. Bagal has a question. Great presentation. What is your experience with Zoll HFMS
With the Zoll HFMS
device?
patch, yeah. So we have done about 50, maybe 60 patches right now. We've experienced it in the outpatient setting, meaning prescribed post-discharge or immediately prior to discharge. And it worked pretty well. We have done the analysis. I'm not presenting you the data. We believe we have reduced our rehospitalization rate by around 40% compared to prior. We have exceeded, as a matter of fact, what we saw in a clinical study that I demonstrated you that the BMET trial was around a 38% reduction. So we were just as good, if not better, in preventing rehospitalization in the way we analyze the data in a single arm fashion. We like it. That's a plus. The downside is the patch is usually only tolerated for, in average, 4 weeks. We prescribe it for 12 weeks. But it's tolerated only for 4 weeks because, in average, the 70-year-old patient that we send home with is not tolerating the patch adhesive. So that tends to be one of the problems that we have with this patch. But there are other patches out there. This is one of the several patches. We also have Sentinel. There's another FDA-approved patch that you now put every day for 2 minutes on the skin. There are fancy scales you can use that are remotely activated to measure water content, et cetera, et cetera. The technology is not a limiting factor. Feel free to reach out to me after the, I'm going to put my email in the chat. Feel free to reach out. I'm happy to debrief you on the technologies we have and how we can collaborate. And again, there's a lot of technology. That's not the problem. They are all great. The better question is, are you having the staff and the plan to manage the data? Who's going to act on the data?
Dr.
Fadim, let me
Fadim, Dr. Fadim, do you see the other question right there?
With
Right
AI
above where you just-
advancement, what specialties in medicine do you think will become more valuable, obsolete? Well, funny you say that. So, I mean, a fellow approached me a couple months ago and I asked her what she wants to do, quote unquote, when she grows up, because she was a general fellow and she wanted to specialize in echo. Well, I said, that might be a bad idea. I mean, I'm no Elon Musk here, okay? But I can tell you we won't need many echo attendings in the next 3-4 years anymore. We already have 2 FDA-approved software technologies that can actively read your echoes that were obtained by techs, but the interpretation and the progress and the report writing is all done by the machine with a much greater sensitivity and specificity than any human eye can do. A human has to read 30, 40 echoes at Duke in a day per reader, per echo reader. Those machines can do thousands in a minute. They can do it at great sensitivity specificity, and they're only going to get better as we teach them. So I think any imaging specialty in the cardiovascular space, CT, MRI, echo, will become obsolete. I mean, this is just my opinion. I wouldn't even train in those specialties. Now, will you need a cardiologist supervising the machines, training the machines? Yes, but you can see how the role changes. You're no longer doing the reading. You're just doing the teaching, the verifying. You become more of a techie guy. So I think that's one. Procedural specialties are going nowhere. The human connection of rounding is going nowhere. But I think the medicine field will change whether we like it or not. So we better embrace the technology. I think there's many AI, ML technology and study-related work going on at our institution. Reach out if you're interested in participating in some of these studies. Dr. Green is participating and leading some of these efforts. So that's an exciting era.
Any other questions on the chat, Mary?
No, that's it.
Okay, let me ask you one thing, Dr. Vadim, and you may or may not know this, but given the really great promise this approach has in heart failure and the cost savings to the system, is there any knowledge about if you implement this, how long it is until the return on the investment is such that the hospital can afford to provide the service?
So what specific service? The remote monitoring, remote care stuff?
Yeah, if you wanted to implement this in Utah is a general hospital, and they had to come from 0 up to doing the level you're operating with, or with a relationship, they're going to have to invest in at least 2 or 3 people, equipment, bandwidth, and all that. I'm just asking, has that been studied about what the cost would be and how long it would take from return on investment to where the hospital was or the health center was appreciating a good response financially from that?
So excellent question. I can tell you that it has been studied. It takes about 250 patients per nurse to make this a financially viable model. So just to give an idea, how many patients can a nurse watch and bill for? This is all billable to be completely self-sustained, around 250 patients. So now we have done the math at Duke, and we're already billing for this. Not only you make at 250 patients, you break even, you can sustain 1 FTE, you actually make, multiple $100,000 profit if you watch a population of 1,000 patients or more. That's per 1,000 patients. So every 1,000 patients more you watch, you get another couple $100K on top of it. So if you think of it as a business, yes, you cannot from day one start billing at a rate because you actually need to ramp up slowly. But I can tell you that every ICD in your system has remote censoring bill. You could turn it on today and have 1,000 patients in your system we already watch. And then, so with a slow ramp, it took us actually 3-4 years to get there, but we haven't been using many FTEs. Now we're getting a lot of FTEs. Now we're doing the chronic billing. Now we're self-sustained. So it's a slow growth.
Super duper. Thank you. Dr. Collins,
Brittany,
question.
Brittany, did you want to ask a question?
Yeah. Hey, Dr. Vadim, thank you so much. I'm Brittany Collins. I'm one of the nurses in Martinsville, Sovah Martinsville, and I'm a heart failure nurse up here. And I'm very excited to hear about the remote monitoring. We actually had conversation, and so there's more to come. Is very early conversations for both campuses regarding remote monitoring. This was a conversation with Ventricle Health this week. So I think we're going to be talking with some of our cardiologists and things like that. So we may be moving that direction. So that is very exciting to hear your information about that. And I appreciate you guys talking with us.
Yeah, fully endorse. We are actually doing a study. You could sign up for them clinically or do it as part of a study that we're doing with them, Elevate HF. I believe it's called, or Evolution HF, one of those 2 fancy names. I think that this actually comes back to Dr. Moore's question. Well, how much does it take to stand up such an operation? Well, it takes a couple of years to get this operation going in a medical center. We are not Elon Musk's. We cannot do it overnight. But guess who can do it overnight? You partner with industry, they're going to do it overnight because that's their business. One thing America is very good at is running businesses. And that's what you get when you partner with Ventricles and Cadence and Ishi. And I could go on and on and on. There's a lot of industry built around this. And I'm telling you, they have good things in mind because they actually don't charge you. They charge the insurance for the services they provide, which is a win-win for everybody.
Thank
And
you.
they don't
Great.
steal patients.
Any last questions for Dr. Fadim? Or for Dr. Green? Now, Dr. Green's with us still too, so.
He's
any
probably
final-
trying
this
to
is
sleep. Everybody's trying to get to bed.
Yeah, well, that's it. We realize that not only surgeons get up very early, so we try to wrap things by 9. But let me thank both our speakers again. I just can't tell you how much I appreciate your enthusiasm, both of you, and your energy. It's so it just makes you feel so good about everything, and that good folks like you are making these strides forward and helping people get better care. For everyone on the call, thank you for being here this evening. We hope you'll be back for the next program. In which we'll have Dr. Tu talking about maternal health equity. And as I'm reminding our residents, please be careful out there. Take care. Have a good evening. Good night. Bye-bye.
Thanks, everybody. It was a pleasure. Great questions.
Thank you.
Thank you.